So again, welcome. We've had a good week so far on our military health track here at AMSUS, and had the opportunity, one, to have, as you know, Dr. Woodson, when he gave his plenary session, it talked about the lines of effort and the strategic vision for the military healthcare system, and what we've been using. If folks that have, I know many of y'all folks have stuck through this whole thing, is every one of our presentations maps directly back to Dr. Woodson's and the MHS's strategic vision, but more importantly, our lines of effort. And so this was an opportunity here to share with you, kind of a glimpse or an insight into one or two of the initiatives and or the ongoings in the military health system that are supporting our lines of effort. I'm going to kind of talk about that this morning because I sort of got the question the very first day after the second lecture, and that was, what about this? What about that? What about this? What about that? And so let me set it up right now. This is an opportunity, and we've had a great relationship with AMSUS, but it was an opportunity for us to give an executive version of the strategic reform that's going on in the military healthcare system. What we're talking about in each one of these 30-minute sessions or hour sessions would have been an entire afternoon at the MHS conference. Okay. So folks need to understand that behind each one of those slides is about 5 or 10 slides, okay? And so I'm going to apologize up front for that. But then again, I'm also going to say, hey, this has been a great opportunity for us at least to get the major message out there and hopefully to pique your interest again to either contact us and talk about us where we're going to go, or number two, pique your interest and say, hey, you want to come work for us, okay? Don't go back and tell your SGs that, though. So they're already getting hammered for that. So Thomas, your mind still, okay? All right. So this is good. So this morning we're going to talk about, if we go way back, and I'm going to kind of share this with you a little bit, kind of set the stage for them. If you go back to the first day when we showed you the organizational structure of the Defense Health Agency, one of the a lot of stuff we did was not necessarily intended, but we'll take credit for it. But this was actually intentional. And under the old paradigm when we had TMA, all right, that's sort of where the managed care was. That was kind of what we call the network care. And then we ran this direct care system via the services, and there was talk, but they weren't ever sitting down the hall from each other. And so we purposely dropped, when you talk about an integrated care delivery system, which we need to use, we talked about that when we talked about the multi-service markets. We talked about that when we talked about modernization. We talked about that, when we talked about how do we get currency and competency. We need to figure out how to do that. And so when we dropped what we call the TRICARE plan inside of healthcare ops, and literally sitting next door to, what we would call the joint first support for the direct care system, that actually was intentional. That actually was intentional. So that whenever we make a decision on either on the network care side or on the direct care side, that we look at what is the second and third order effects. We tried to do that before, but the physical organizational construct is now you have to do it that way. And so that's what's exciting as we move forward. And so what we want to use is this. We're going to use this next one or two briefings to talk about really a fundamental approach on where we are, but where we think we're going for this, kind of what we're calling an integrated healthcare system. And when we talk to Kaisers, and when we talk to the Intermountains, and we talk to all these folks out there, we think we're unique. We're not, because there's also a direct and an indirect care system for all the other healthcare plans out there. And it's amazing how much we've been able to learn from those folks and say, we have the same problems, so we're not so different after all. And so we've really been appreciative of a lot of our mentors out there that have helped us and shepherded us along the way. So without any further ado, I'm going to ask, again, Major General Tom Thomas, the inaugural director for healthcare operations, to kind of give you a peek inside the tent of where we're going with the TRICARE health system. Thanks, Tom.
Thanks, sir. Okay, well, good morning, everyone. Thanks for being here, and thanks, sir, also for kind of setting the stage as we move forward. Am I in control of the slides? I think I am. Okay.
Well, you don't have to. Here, right there, right
You
there,
get 'em?
right there.
Or I can run the slides, I
Well,
guess,
but
right?
we-
Or is this it?
Yeah.
Oh, okay, I'll do them. I'll
You
get
want
them,
to-
sir.
or we got a whole front row.
I get them, as long as this thing works. Let's see if I can master this thing. What we've set up for you this morning is actually kind of an introduction to the Defense Health Agency, how we got there. And I'm joined by, this morning, the first brief will be my partner in crime here is Captain Ed Simmer, who's recently joined the Defense Health Agency approximately almost 2 months ago. He came out of command at Oak Harbor up in the Great Northwest and has joined us as the Chief of Staff for our health plan. And as you may have seen in a previous presentation, but you'll see it again here later this morning, is our health plan used to be the TMA, all right? And that runs our TRICARE next generation contracts, which is a big project they're working on right now. And they're tucked up under the Healthcare Operations Directorate within the DHA. So, let me see if I can manage this here.
Say, all you got to say
Got it.
next slide and it'll happen.
Who is sir? Got it.
Trying to help you out here.
So the agenda, there's some things we want to talk about, the highlights here. A little bit of historical perspective. The boss has already kind of touched on this again. We didn't just stand this thing up without a long history and a tale here. And it's good to see some of the folks here in the room that I had a chance to, General Adams and some others that are here this morning. Thank you for being here, but also thanks for your service and thanks for actually setting the stage for us right now. We stand on your shoulders. You know, a lot of the work, a lot of the groundwork for the current Defense Health Agency was laid by folks in this room and others that have worked a long time in setting conditions so that we could actually have the first jointly staffed organization such as this. And I'll give you a little bit of that historical perspective here in a moment. But this is kind of the world we live in. We live in a dangerous world. I like to throw this slide up there because if we took out Iraq and we took out Afghanistan out of the equation, which, oh, by the way, there's still a shooting war going on. You wouldn't know it by watching the news most days. But we still have troops, U.S. troops engaged in more than 120 countries around the globe. And this is why we have a military health system. The reason. Since 1776, American military medics have been with our troops in every engagement we've ever had as a nation. You know, from the lawns of Lexington to the grass at Gettysburg, you know, to the sands of Iwo Jima, and certainly in modern times to the deserts of Iraq or the mountains of Afghanistan, and 1,000 other places where we've had troops engaged over our history. We've always had American medical personnel there engaged with them. We are not Kaiser Permanente. This is why we keep in uniform. But we understand that we're a two-tiered system, we're a multi-tiered system. We have to have our uniformed medical professionals, and we also have to have our civilian professionals working with us. And in our complex world that we have in our system right now, as we'll show you here and we'll talk a little bit about more in a moment, is that we also have to have engagement with our civilian partners and healthcare organizations. I think that whether you're looking at combat operations, humanitarian assistance, or disaster relief operations, they will continue into the future. No one predicted the ISIS issues that we have today a year ago. It wasn't even in the news. So we have emerging threats continually. This is why we must maintain a military capability and certainly a military health capability. We're the best in the world at what we do. The innovations, major innovations in medicine primarily come from us, whether it's Walter Reed curing yellow fever, Michael DeBakey setting up our combat support hospitals, which we use today, or 1,000 other innovations. We talked this morning, sir, about the Joint Trauma System as a good example of innovations that come from the battlefield. Combat has always been the greatest catalyst for medical innovation, and that won't change. The medicine that we practice today in the military becomes the standard of care tomorrow, and that's nothing new. So it's very important, it's vitally important. If you get my point here, and I'll foot stomp that, is we've got to keep a strong military medicine capability. It's vital to us. Okay, so historically, this is where we came from. Since going back, there's been since 1947, I think that's about the time that the Army birthed the Air Force or something like that. If you go back, there's been no less than, hey, Ed, there's a reason hey, sir, there's a reason I got Ed between you and me. Well, there is
call that treason. We call that advancement. Yeah.
No, I'm good. I'm just, hey, help me out here, man. HBO, help a brother out, Ed. All right, so since that time, we've had nothing short of I think you can count here, about 18 major panels, commissions, and studies that have come together to look at the military health system and how we can get better. How do we do things better? How can we be more efficient? Because we're costing a lot. Are we getting our, the squeeze for what we're doing, that kind of thing. And you can see here that 15, the so what on this slide is 15 of the 18 major commissions, panels, and studies that were conducted since that time have all agreed that we've got to be a little bit more joint, a little bit more unified, a little bit more cohesive, some increased central authorities and some kind of organization to get after this. Now, there are 3 of them said, hey, let's just go to, the separate services. Let's just do our own thing. But, really, those are the outliers. Then in 2011, the most recent commission that was put together was the MHS Task Force, and it was co-chaired by General Doug Robb and General retired Peach Taylor. And it had our, I think our current surgeons were all involved in that team. And they did, I think, sir, really, and as I worked with you on that panel, they had more accomplished in a few months than the previous ones had done in several years in some cases. But they came down to the decision point that we've got to have something that has a joint organization with more increased central authorities, and the combat support agency model was a pretty good tool to use. So they worked that through, briefed it up through the chain of command, and they agreed, yeah, that's a good way to go. So it's an evolution, is my point, and that's how we got to where we are today. I thought this was an interesting slide, and I want to thank Ed and Mark Ellis, who's here with us today. Where's Mark? Mark, and he'll be joining us on the panel too. Thanks, Mark, for being here. He works in our health plan. More than 30 years experience in military medicine, retired Air Force Medical Service Corps, Mr. Ellison. So we got team members like that with us in the organization. But thanks for this slide, because I thought this was interesting when I looked at it. This is kind of the history of the TRICARE program. Starting from the left and moving to the right, you go back in the 60s when Medicare and Medicaid were initially stood up. Shortly thereafter, the CHAMPUS program was instituted. And then they, of course, as you saw on the previous slide, there was a CHAMPUS reform effort. It has to happen not far after that, kind of in the mid-'80s, late 80s to 90s. And then TRICARE was started. 1995, I remember I was at Madigan Army Medical Center when the first TRICARE regions were initiated out there. Then you see the evolution from left to right. 2001, TRICARE for Life. And then 2003, we started things like mail order pharmacy. What you're seeing here is the evolution of a system. A lot of tools being put into play, and it's, when people talk about TRICARE, one thing I've found when I've talked to some senior leaders, and including some very senior leaders, is they don't know really about our system very much. They kind of know that, hey, if I get an appointment, or the more senior they are, the more divorced or the further away they are from the reality, because it's just like, my aid man makes that happen for me, or, I just say I need the pills and they show up, that kind of thing. So they don't understand really what goes into this. And so as we have gone on our journey here with General Robb in the last year to educate folks, they begin to understand really what the TRICARE program really, it's a family of programs and what's on the menu for them, and they're more appreciative of it. The President's Commission on Retirement and Benefits, we've been over there at least 4 times talking with those guys as they're doing their study. And the education, really it's to educate them. Now they know that we've got the great pharmacy program that we do, the great TRICARE program we do. Previously they didn't understand that, and some of these guys were retired senior military officers. So anyway, an evolution across the spectrum. At the bottom you see they originally started out in TRICARE with 12 regions domestically, plus an overseas contract. And then about the mid-2000s there, we've morphed to the current 3 domestic regions and 1 overseas contract that you see today. And we're not done. We'll continue to morph what we have and evolve over time. This is kind of the founding or the governing documents that got us to where we are with the DHA. 2011 task force I mentioned, and on the left you see the DoD task force. The report of that, the findings of that group that were briefed, recommended the Defense Health Agency as a model for a combat support agency to help affect MHS, Military Health System Governance. That was then followed by in 2012 in the spring with the directed implementation plan for health affairs and the DHA to include the shared services, and talked about the multi-service markets, which you're hearing about today. But some of these terms become commonplace to many of us here in the room, but as I found last night in the discussion with some folks over dinner, that some people still don't know what multi-service markets are, and that's okay, because we still have a lot of education to go. Just this in March or spring of 2013, that was the directed implementation plan for the key activities. That really get the fire after the Defense Health Agency, the shared services, the National Capital Region Medical Directorate, et cetera, et cetera. And then that's when General Robb and others initially packed their bags and their CAC cards and moved over to stand up the DHA in just the fall of 2013. So they're just a year old. They're still IOC, initial operating capability. They'll move to FOC 1 year from now, October of 15. However, as you'll see in some subsequent slides here, as we're talking about the maturation of the system, it's not all at one time. These shared services are kind of interesting. Some of them are more mature than others. Others need to marinate a little while longer. But it all will come together with the continued, consistent collaboration, cooperation, and coordination with the services. Believe me, the thing I tell the services when I talk to them, to include the chiefs of staff, is it's not about the DHA getting inside your medical motor pools and kicking drip pans. And once they hear that, they relax a little bit. They begin to understand what we're about, that we are there as a customer, a supporting and supported relationship as a combat support agency to help these services enhance their efficiencies, to deliver high-speed, state-of-the-art medical care across the spectrum, and to do it more efficiently, more effectively, and obviously we're looking at cost savings whenever possible. And I'll talk a little bit about that too. Okay, so I'm not sure about this one, but I think it does depict from left to right, kind of showing where we are, the same thing I just talked about. Then in the spring of 2013, some of the key tenets that came out as we moved towards IOC in the fall of 2013. Initially, they said, let's select a DHA, Defense Health Agency Director. It's got to be a joint selection. Nominations were taken from all the services. They picked the best athlete, and he had to put together the team, okay? And that's what General Robb has been doing since then. The 10 shared services, the assessments were initiated. The services worked together to identify the initial 10 shared services that they could get after. These are things that we all do similarly. These are big targets for us to try to gain some efficiencies and save some money along the way. For example, medical logistics. Why do we have 16 varieties of surgeon's gloves on the shelf at any given time? And as a surgeon, I can say that because we can, right? But if you let us do that, we will do just exactly that. We've got to put some discipline in this. Someone has to herd these guys together, right? So, it wasn't just a matter of you guys giving us surgeons a chew toy to play with while you did something else. It was actually, kind of figuring out how we do this better. So putting some discipline into the system, changing contracts, and I'll show you in a subsequent slide some of the things our great pharmacy director, George Jones, has done just by tweaking some contracts in the short term and some longer things to save significant amounts of money. We can do business better. We've got to show the way. Just as we are the ones who innovate on the battlefield, no one would argue we have the finest vertically integrated trauma care system in the world. We developed that in military medicine. It's a model for others to emulate. We should be the model of efficiency in how we practice medicine in other ways too, and we can be. And I think that's the journey that we're on right now. Continuing from left to right, October 2013, the DHA became now operational. They folded the tent on the TRICARE Management Authority, and the NCR Medical Directorate then was established, and we continue to mature. 5-year business performance plans were initiated. We work with the services to do those 5-year business plans in the enhanced multi-service markets, and I'll hit on that again here in a future slide. This fall, October, at our 1-year anniversary, IOC, the enhanced multi-service markets were fully operational. Their 5-year business plans were worked, and they were approved, and they were put into the FY15 budget. A significant milestone. And then this was the result of really close combat coordination with the services. They've been intimately involved in this process. As we move to the fall of 15, as I mentioned before, as we go to FOC, or full operational capability, the MHS governance transition will continue to be reformed. One of the key elements that we've had that's been evident to us as we've gone forward is inserting that MHS governance process. It's the first time we've ever had a formalized governance process. Previously, things were either done or they weren't, or they all of a sudden popped up to a very high level for adjudication. And if that, oftentimes what happens then is you're taking the medics out of the decision tree, and that ain't good for any of us. All right? I love the gunfighters, but by God, I don't want them telling me how to do stuff necessarily. Just like I mentioned to a vice chief of staff the other day, I won't mention the name, that I don't tell you how to drive your tanks or fly your helicopters. Although I could learn how to do that a lot quicker than you could learn. So anyway, you know how that conversation went pretty quick. So Anyway, I show this. I would like to slip this one in here because this is Dr. Woodson's, his quad aim, if you will. Now, this wasn't an original thought. This was actually kind of adopted from the Institute of Healthcare Improvement, where they have, let's deliver better care at a lower price with better outcomes. The difference is in the center, readiness. That's what we're about. So readiness, you could ask 15 people what the definition of readiness is, and they give you 15 or more different answers. But the issue is that's what we're about, enabling the warfighter so they can go to sometimes very dangerous and bad places and deliver very good medicine. That's what makes us unique. So this is the quad aim. This is a strategic true north, if you will, for the health affairs and the MHS. In here, you talk about the 3 bullets on the left. He said, let's look at this thing as look at our readiness platforms and take a market approach to enabling their business practices to increase that efficiency and lower costs that we're after. The multi-service markets are key in this respect, and I'll show you where we're talking about focusing. But they're not the only things we're talking about. Just because you don't happen to be in a geographical area that's a multi-service market doesn't mean you're not being looked at, or you can't benefit from some of these approaches. Absolutely you can. But remember, those MTFs, those military treatment facilities within those markets, are service hospitals. They're not DHA hospitals, with 2 exceptions actually in the NCR. They're service hospitals. And so our support efforts to those services to enable them to run their hospitals more efficiently and deliver better care. And that is the issue. And then to have accountability, have metrics, have targets for them to shoot for, standardized targets. And for the first time, we've got those standardized metrics for the markets, and I'll show you that in a slide coming up. So the EMISMs really are kind of the models that we're after. Models of efficiency, we think from there, if you demonstrate success there, then you can matriculate that across the force, and we'll be better because of it. A fully integrated military health system with a readiness focus. That's the vision. Sounds good? We briefed it to Secretary Woodson, I think almost a year ago. He gave us a thumbs up on that. He said, General Rob, I think that sounds good. I'll take it. So that's what we're going with. Okay, so a couple components here. I'm going to ask, before I turn this over to Captain Simmer in a moment, but I'm going to talk a little bit about what we're integrating. Right now, we've got a direct care system, and we've got an indirect care system, or purchase care system. The days of a hospital commander standing there and saying, oh, that's a TRICARE patient, ain't my worry, are over. They're all our patients, and we must own them. What we've done over the past year, we did a series of 6 blue ribbon panels because we have a big Manhattan project right in front of us. One of the Manhattan projects we're working on is the next generation TRICARE contracts, TRICARE 2017. So we brought in all kind of folks from industry, from the military, sitting commanders, hospital commanders, and asked them a lot of questions. What would you like to see that contract look like? And on the same time, we're talking to industry and looking at their best practice and saying, you guys have cracked the code on a lot of this stuff, and you know how to make money off of it, so we should do a little bit more like what you're doing. What we found was, across the spectrum, even sitting commanders, even some very senior folks, they don't understand what that TRICARE benefit's all about. So it's an education for us. We've targeted them. We're helping them. We're going to do better with that. The way we change a culture is through education. So they're all our patients. So the marriage, and the marriage counseling continues, by the way, between the direct care system, the indirect care system, and the services, is those are all your patients. And you look at that bottom bullet. In the direct care system, we only deliver about 25% of the health care in the MHS. A lot of folks, it's surprising. They see how much care is actually delivered in our purchase care side. So we do have a vested interest in making this work. And that collaboration between the two, and you'll see that that's what we're modeling in the enhanced multi-service markets, is that seamless integration, if you will. You can't be seamless if the edges aren't touching. And so we want to open up those gates between what's happening inside the gate, the MTFs, and what's happening outside the gate, and bring them together. So we have a bunch of initiatives in order to get that. The boss said a moment ago that there's 10 or 15 slides behind this one. Who, sir? There is. I'm not going to show them this morning, but you think about that was some of the things that frustrating or the stall points for us were things like emerging technologies and treatments. Why? It always frustrated me, especially as a surgeon. I said, why can we do bariatric surgical procedures in our MTS, yet we won't pay for them in the TRICARE market? Or why can we deliver some laboratory-developed tests inside the hospitals, but we won't pay for them in TRICARE? Why? Because we're stuck, usually by policy or in some cases by statutory restriction. I got it. But now we have a DHA, and what we've done is, for one thing, is in emerging technologies and treatments, we've got a demo where we can throw some of these things into that demo and make sure that we're providing the care inside the gate. We're also doing outside the gate. Therefore, we've got the standard of care delivered across the spectrum. But we also have an opportunity now to get the outcomes on that and make sure we're moving ahead. All right, and there's dozens of examples of that, and I've got files and headaches from some of those, but it's okay because it's all good work as we're getting after that. And I'm happy to say that 2 evenings ago when the NDAA was released in Section 704, take a look at it, because that's going to help us out quite tremendously with that. Okay, so on the purchase care side, here's what we kind of look like. As I mentioned, about 75% of the care to our military beneficiaries, there's 9.5 million folks out there, is delivered in the network. So it is our business. These are our family members. These are our retirees. These are our troops that are out there getting this care. So we have a real interest in making sure that we're partnered, snap-linked very tightly with our purchase care, our managed care support contractors, and delivering the best care possible. And I have to say that the current 3 contracts that we have, CONUS and one overseas, these are great organizations. For those of you that were, I was actually on the Army side, the Western Region Medical Commander when we did a transition to the new contracts in the West. And you got a lot of bad pub, but I'll tell you what, it's working very well, and it's because of the integration, the hard work, and professionalism of those in United Healthcare and those on the military side that got after it. All right, that's what it takes. It's that good coordination, professionalism that so we can do anything we want to. It's not the first nor will be the last time that we've had a few hiccups along the way. Like I mentioned, we do have a draft request for proposal on the streets right now, and we're getting questions and comments back from industry on that. We want to make a better contract. All right. We don't want to have a 47 Packard. We want to go to a Ferrari. All right, and it's an iterative process. And that's what our goal is in the future. So, okay, I kept mentioning to you, I think several times, the enhanced multi-service markets. Is this familiar to most folks here? You guys have seen some of this stuff, They talk about the 6+2, and then when you say +2, then my Navy colleagues get nervous. Army colleagues, they start sweating a little bit, the +2, because the +2 is really San Diego and Fort Bragg, North Carolina. They're not multi-service markets. They're primarily single-service markets for the most part. But they're big markets. If you count up these 6 areas here, these starred areas across the map, starting in the upper left there, northwest, that's a Puget Sound, EMISM, then Colorado Springs at numeral number 2, Hawaii at 6, San Antonio down at 4, and you've got National Capital Region number 1, and then Portsmouth, or the Tidewater, EMISM, at number 3 on the East Coast. More than 50% of our direct care population resides in those areas. So those are major targets for us. All right. If we can't do it there, if we can't do it right there, we can't do it. And so this is where we're going to demonstrate success. Now, why it's important to us is each of those markets there has a group of MTFs, service MTFs. Pick number 5, for example, in the Northwest. The mothership up there is Madigan Army Medical Center. It's huge. Great capability. I think they have 40-some programs, GME programs up there. They've got a whole Army Corps stationed up there at JBLM. They have a huge population. You've also got Oak Harbor, Bremerton Navy. You've got McChord Air Force. So it's a multi-service market that takes care of a heck of a lot of folks. Okay, if you look at that market up there, they have and it's kind of the model that we're after, the mothership, which has a lot of graduate medical education, so that's one of our training platforms. And really, our operating force is our generating force in medicine. These are the folks that go to war with us. So it's a training platform, therefore it's a readiness platform. As I mentioned, they've got a lot of combat forces assigned up there, but they also have a lot of medical forces, both on the combat side and also the institutional side. So generating force, operating force, contiguous. So that market up there is important for us. We got to demonstrate success. We want to be more efficient. As I said, there's no, I trained at Madigan, which in my surgical training up there, my running mate was an Air Force officer. One of the residents right behind us, 1 year behind us, was a Navy officer. So we were, medicine really has the opportunity to be the model for jointness, if you will. Because I found out, even though I didn't believe it at first, that, the Navy and the Air Force guys, they kind of tie knots and cut skin the same way that we do in the Army. It's amazing. And then when we're deployed into theater, whether it's Iraq, Afghanistan, or whatever, I work with these guys too, and we kind of do things the same way. So I think the Army always does a little bit faster and better, but they kind of follow the same pattern, if you will. But that's just me. Anyway, so we can be the model for joining us, and we are. And when we've been deployed downrange, we always are. We get along just fine. It's when we come back, we get in this food fight, right, typically. But anyway, so within these enhanced multi-service markets, we've got a high population, direct care population target for us. We've also developed those 5-year business plans, as I mentioned. The DHA kind of oversaw that with the services, worked with them, and developed those market business plans. So you still have Army, Navy, and Air Force MTFs run by the services, but they're looking at them from a market approach. So you take a step back and say, what's good for the market here? Now, I understand in the Portsmouth or the Tidewater market, maybe Fort Eustis Hospital has to give up a little bit towards Portsmouth Navy so that it's a market benefit. Okay, understood. It doesn't mean you're still not measuring and holding people accountable for their separate organizations, but it's a group or a tribal effort is the point that I'm trying to make here. So now they have business plans with, importantly, standardized metrics, which is the first time we've had those standardized metrics. And let me tell you what, the governance structure we have in place to include the medical business operating group, flag officer led, the services get together, tri-service, talk about those metrics. They had a nifty 50 list. And for me, I said, let's keep it simple. Can't you get me down to the top 20 or maybe the dirty dozen? And so with a lot of marital counseling, they did. They got it down to, a reasonable number. I think we got the top 10. It doesn't mean the services can't have additional metrics, and they do. That's fine. But the ones we're looking at from a market perspective are the ones that we want to follow carefully so we can make sure that they're making progress. Going back to the quad aim, they're doing it more efficiently with a better outcome, lower cost. I think I beat that horse to glue. So what I want to do right now is I want to turn it over to Captain Ed Simmer, who Ed's been with us, as I mentioned, for about just short of 2 months now, and just came out of command at the Great Northwest Oak Harbor Naval Station, and he's a psychiatrist by training. That's kind of one of the reasons we brought him over. He works with me very closely, as you might imagine. And he's a great American, a very experienced medical corps officer. And so he's also now our chief of staff for the health plan. Ed?
Thank you. Can I get the mic? Absolutely. Let me take a little time to kind of inject another example. When General Thomas was talking about the mothership, and for folks that were here before, you heard this story, but those that haven't, this is important. And this is fundamentally the difference between the way the world was 2 years ago and the way the world is today. From the multi-service market perspective, in other words, the graduate medical education, it's important that the more patients you have, the better. Okay, in other words, it feeds your GME, but also your currency and competency. So what happened up here in the National Capital Region here recently was the multi-service market director, okay, with her multi-service market staff, okay, was doing what I call the radar sweep for the market analysis of what's going on out there. And for the first time that I remember in my career, okay, we had an outsider from a market perspective telling a service, I think you're under-enrolled. I think you're under-enrolled by 2,000 people, And so when you think about that, the answer is why would that market director do that? Purely selfish reasons. Because she wants to feed the big house. Because she wants to feed the GME programs. So when she's looking out there, so that's what's great about the multi-service markets. If you give them the authorities to speak in public, okay, and to point out, hey, we can make this market better for all of us, okay? One, it's a business decision, because the more we get in the direct care system with the sunk cost, the better off we are. But also the real reason she wanted to do it was for graduate medical education and a currency and competency. So the more that enroll primary care, the more we feed back to the big house, because if they're seeing downtown, they're going to leak downtown. And so just that one example was kind of a beginning and an early win for us on why it's better to manage for the market, because that wasn't happening when the services were looking at it by themselves. It was looking at it from a market perspective.
Thank you, sir. Well, good morning, everyone. Great to be here. Thank you all for coming. So let's talk a little bit about how we're going to get this integration done. We've talked a lot about what we need to do, so how are we going to get there? Well, one of the main ways we're going to do this is using the eMISM model that we've already started to discuss. Two things with an eMISM. One is there is a market manager, as you heard. Usually the lead of whatever the largest MTF is in that area. So for example, where I was in the Great Northwest, we had General Thomas. So we had an Army lead, which actually worked out very well, except on, of course, the first Saturday in December. Thank you, Master Chief. But
Wait a minute. We're not going to let that go by. All right.
So,
However, it's playing for second place. As we know, that trophy is already on its way to the Air Force Academy. Thank you very much. As it should be. I'm joint until it comes to the gridiron.
So, speaking of that marital counseling, but anyway, so the market manager is responsible for the entire business plan, everything that happens throughout all those hospitals. So, as was mentioned in our example, Air Force, Army, Navy facilities, most of the multi-service markets have that. And it includes the ability to move personnel around. It includes the ability to move patients around when it's appropriate. Always focused on maintaining the readiness and maintaining the best quality of care. There's a 5-year performance plan. You know, in the past, at Oak Harbor, our only performance plan went down to the Navy in San Diego. And it was very specifically focused only on Naval Hospital Oak Harbor and what we did in our own little, you know, our own walls. So, but now, instead of that single focus market, we have looking at how does Oak Harbor contribute to Madigan, how can Madigan help Oak Harbor? So for example, Madigan gave us a lot of telehealth equipment so that we can now do a lot of telehealth with the folks at Madigan, keeps the care within the direct care system, helps the GME. Our patients love it because they don't have to travel somewhere to get the care. So we get better care, we support GME, and we keep it in the direct care system. So that's just one example of some of the things these eMISMs can do that really help everyone. As I mentioned there too, there's a budget execution process, so that we're looking at funding now across the entire market, not just for a single MTF, which I think broadens the vision and encourages some of these cross-pollination things that really do help improve. But there are also some things we're obviously not going to change. We're not going to change that our number one focus is readiness. In fact, the eMISMs are designed to improve readiness, increase readiness. Again, if we can provide more care within the direct care system, if we can provide that care faster, decrease the wait time, we're going to have a more ready force. By improving GME, we're also going to make sure our medical force is more ready. So not only are our troops more ready, the medical force is too. It supports the military mission. You know, I can tell you that certainly where I was, the military commanders would much rather have their sailors or soldiers or airmen come to the military treatment facility. That's what they wanted. And this gives them the opportunity to do that to a greater degree. We also have quality care this way. Again, we're providing better care. We're providing care within the system with the ability of things like telehealth or moving people between the facilities. You know, for example, in our situation, Bremerton had more capacity for psychiatry than Oak Harbor did. So we could get some patients seen at Bremerton, get them in faster, get some great quality of care, and improve the access. So a win for everybody. Now let's talk about transforming the TRICARE benefit, which is the part of this that I really want to focus on. First of all, a lot of people just think about TRICARE as a single entity. But if you see there, we actually have more than 10 different TRICARE contracts. We have regular TRICARE, we have TRICARE overseas, TRICARE for life, we have the 3 dental contracts. So there's a lot of different things that make up TRICARE. And right now, not only does direct care not always talk well or work as well as it could with the purchase care system, sometimes those contracts don't even work well with each other. And that's another part of this whole integration that we need to focus on. So what are some of the things we're looking at? Well, you can see there on the right side. Changing how we buy care, looking a lot at that. You know, right now a person goes out in town, specific service, you get a bill, you pay the bill. Is that really the right way to do this? You know, there's many different ways we can do that may be better than the current system, which is basically the system we've had since you saw that slide in 1965. A lot of things have changed, but the basics of how we buy care haven't really changed very much in 50 years. Data sharing. Right now, if I want to get a medical record from a patient who was seen in the purchase care system, we have to do something called a clear and legible report. That means they fax us, or maybe they mail us, depending, a report. Hopefully we can read it when it comes. Hopefully it does come. It doesn't always. What if we had one interoperable medical record that not only worked within the MTF, hopefully better than Alta, but also worked, that the purchase care system had access to that medical record, the VA had access to that medical record. What if we were all documenting in the same record? And it was electronic, so it's basically instantaneous. So when, that purchase care doc is putting a consult in the system, 10 minutes later the PCM can see it, and it's right there for him. It sounds, a pretty far reach, but we're actually, I think, closer to that than you'd think. Again, leveraging the eMISM best practices, and we actually have an example slide I'm going to show you, so I'm not going to spend a lot of time on that here. Emerging technologies in treatment. That's that section 704 in the current NDAA. We're really focused on how do we make sure we get folks the best care, the most modern care, as soon as possible. We obviously want to make sure the care is safe, it's evidence-based. We don't want to lose that. But at the same time, we don't want bureaucratic hurdles in the way that prevent us from providing the most modern care possible. Aligning incentives with health outcomes, really important. Some of this you'll see in my next slide. I'll show you how this is going to progress over time, so I'll talk about that more then. But clearly focused on, we want to incentivize positive outcomes, good outcomes. And we want to reward providers, facilities on the purchase care side that give us good outcomes. We also want to reward that on the direct care side. And finally, referral management reform. Referral management, for those of you who've lived that process, know it doesn't always work as well as it should, especially when you're referring from direct care to purchase care or back. There's some real barricades there. And so we really want to focus on how do we get rid of the barriers, how do we make this as seamless as possible for the patient, so that for the patient it really looks like one system of care, which is really the ultimate goal. So let's talk about how is this going to progress? What is our plan? Well, first we have near term. What can we do basically right now? What can we do before we award the next contract? So in the current contracts, which run more or less through 2017. Well, we've already learned some lessons from the transition out of the T3 contracts. It was mentioned before in the West region, and I was there when this happened, there were a few bumps along the way when we made the transition between contractors there. I think we've learned from that. It's much better now. I can tell you when I left in August, it was 100 times better than a year ago. So we've made a lot of progress. We've learned lessons from that, and we're already applying those lessons as we plan for the T2017 transition. Manual reviews. There are TRICARE manuals that basically govern everything we do. These huge, thick, and we don't print them anymore, but these immense files of material, information, that basically talk about what's a benefit, how do you get paid, everything you can imagine. So we're already working on reviewing those and making that process faster. Right now it takes a long time to get a review through, get a change made. We're trying to make that faster, again, so the system can be more nimble and we can more accurately reflect the current state of practice. Now, obviously benefits are governed by statute and regulation. So in the short term, that's probably not going to change very much, except for the things like in the NDAA. But one thing we are planning for and are looking for, you may know that in the new contract upcoming, we're going to go from 3 regions to 2. That is the current plan. So instead of having a west, north, and south, we're going to have an east and a west, which I think will have several advantages for us. First of all, the more regions you have, the more different people you have working on things, the more different solutions you're going to have. That's not always bad. That means you may find a better solution. On the other hand, it means there's more risk of lack of consistency. And it's a problem we see. Patients complain, hey, it was one way when I was in the west, now I've moved over to the north, and it's different. Why is that? Why isn't the care the same or the process the same everywhere? And that's a fair question. So I think by going to 2 regions, we'll solve not all of those problems, but some of them. It'll make it easier. We have some changes to how we're working the TRICARE regional offices. As you'll see on an upcoming slide, we're going to have 1 TRICARE director over all 3 of the TROs, instead of the old model, which had 3 separate directors, which was a little more unwieldy, I think. A couple of unknowns. We've mentioned the Military Compensation Commission. We don't know for sure what they're going to recommend. They should be reporting out here this spring. But obviously, once we see what their recommendations are and then which of those recommendations are going to be adopted, we're going to need to flex to that. We're going to need to make sure that we incorporate that. The EHR, the Electronic Health Record, that's a very active process right now. A lot of people coming on board to help us with that. And how that EHR turns out and how that works out will help govern how do we make this interoperability? How do we make sure that that's workable across both the purchase care and direct care systems, which I think is going to be a really key portion of this overall integration. If we're all working off the same page, all working off that same record, it's going to make everything else a lot easier. Midterm, so what comes with 2017? So As it was mentioned, that's currently out on the street. T2017 is actually out for comment right now. If you can go to the TRICARE website and see it, read it. If you want to make comments, you can do that. The comments close Monday on the 8th, so you need to do it soon. But everybody's encouraged to do that, and we have gotten a lot of good feedback already, and we're hoping certainly we'll get some more. One of the things, as I mentioned, we're going to have a single TRICARE CONUS director. We actually hope to have that very soon, where there'll be one director for all 3 regions, and then when the time comes, both regions. Bridging strategy. T2017 is not massive change. It's incremental change. I think you'll see that if you read through it. But it's a great first step. So this is the first step. It's basically a bridging strategy to what comes next, which will be the next generation of TRICARE contracts after T17. What do? It syncs all 3 contracts. It really brings things closer together. We're really focused on improving the consistency across the 3 regions, and then 2 regions. Really want to do that. Obviously, if we only have 2 contracts instead of 3, there's less redundancy. There'll be some cost savings with that. And there's some improvements to the current delivery model. We already mentioned the emerging technologies piece of that. That's going to be key. Another thing, though, that we're going to do is we're going to have some incentives in there. So, for example, there will be incentives, increased incentives for the contractors to send more care to the direct care system when it's appropriate, when they have the capability and the capacity. Big focus on that. So if we can incentivize sending care back to the direct care system, hopefully that 25-75 ratio, it's not going to change drastically, but hopefully we can get that 25 up a little bit and that 75 down a little bit. And that's part of our goal. So longer term. Don't know for sure what the longer term is going to look like yet because, as General Thomas mentioned, we can't always predict the future. There will be another ISIS, hopefully not quite like that, but there will be things out there we don't expect and we're going to have to react to. But we're trying to put ourselves in a position where we're as flexible as possible, and we're thinking ahead as much as we can so that we can look at things like, how do we buy care? What are the right ways? There's many ways to buy care. We can do it, we keep doing it the way we do it now, basically fee for service with some limitations. We could do some things like, something closer to capitation is certainly a possibility. And there are other options we can do that would significantly transform us and bring us much closer to our goal of 1 system of care instead of 2. So that direct care and purchase care are both part of the same system. And again, for the patient, it's all one. They go to the direct care system, they go to the purchase care system, they get great care. The information flows flawlessly, and they never see a difference. And that would be the ideal. Reforming the TRICARE benefit, been lots of talk about that. And without getting into too many details of battles that are yet to be fought, I think the TRICARE benefit will probably be somewhat different in 2020 than it is today. I think that's a reasonable expectation. How it will be different, I'm not sure. But certainly, I think you will see there will be significant changes, not only in how we buy the care, that's a big part of it, but in what the benefit is, what it covers, how we respond to emerging technologies, all those kinds of things, how we incentivize care. Can we, for example, incentivize providers for good outcomes? Definitely something we need to do. We do it in the direct care system, not always perfectly, but we do try to do it. And we're pretty good at measuring at least some outcomes in the direct care system. We need to get much better at that in the purchase care system. So we need to be measuring outcomes. Know which providers are providing the best care, which providers the patients go, they get better. And then let's route the patients there. And let's reward those providers or those facilities that have the best outcomes. A real big focus. That doesn't happen overnight. It takes time to put that kind of infrastructure in place. But I think it's going to be key as we work to transform the benefit. And finally, as I mentioned there, aligning incentives with health outcomes, that needs to be something too where we're measuring more similar things across the system. Right now, as an MTF commander, I had a pretty good feel for a lot of our quality metrics. Not as good as I wanted, but I had a pretty good feel. I didn't know much about what the purchase care system was doing. And I think this is an area where we can make that better. So we can not only align the incentives with the health outcomes, but we can make those outcomes measured the same or similarly, at least, on both the direct and purchase care side, and share that information internally. And I think that would be a big plus for us. Okay, so in the end, the primary goal here is still improving care. That's what we want to do. So how do we do that? Well, first, as I mentioned, the 2 regions integrates and streamlines, makes things more consistent, and reduces some of the redundancy. That'll be better for the patients. It'll also hopefully save us some money. Electronically processing referrals. I mentioned to you referral management's a problem. If we can process all the referrals electronically, it'll reduce the admin burden on the MTFs. You won't need 3-4 people working on referrals, which we have now, and hopefully decrease the wait times, make it more seamless. Very important, using standardized metrics, using analytics, predictive modeling, so we know in advance what to expect, what to prepare for. And, as I mentioned, we can use the same metrics across the system so that the purchase care side and the direct care side is being measured the same way. We can compare the two and make some decisions about where's the best place to provide care. I mentioned the incentive programs a little bit, so I won't cover that too much more. But again, the next one, they're sharing data across the enterprise. I can tell you one of the things that I think we need to focus on, as I said, is the MTFs don't always know a lot about what's going on in the purchase care side. And I suspect if purchase care folks were asked, they'd tell us the same thing about the MTFs. They don't always know what we're doing either. So we need to do much better at that. And I think we're moving in that direction, but there's a lot more to do. And then finally, the healthcare technologies and treatments. We want good ideas. All good ideas do not come from the direct care system. There's lots of great things going on the purchase care side, lots of innovations, lots of new ways to provide care, and we need to make sure that we're hearing those, learning from those, and then, if one region or one facility has a really great idea, let's spread that around. Let's make sure everybody else knows that so we can get the quality of care improved across the system, not just in one location. Very important. So, nobody said this is going to be easy, right? I've got 3-year orders here, and I'm not sure how much will get done in my 3 years. I'm hoping quite a bit. But it's going to be challenging.
A lot more than you think.
Yes, sir. So.
Rater, senior rater.
Aye, aye, sir.
Rater, senior rater, okay? You
Yes,
got
sir.
that?
I got that plain, sir.
All right. Carry on.
Aye, aye. So, the first thing is integrated, just like a lot of different terms mean different things to different people, what's an integrated healthcare delivery system? If I asked everybody in this room to write down an answer to that, I'll bet I'd get a lot of different answers. That means different things to different people. So the first thing we got to do is decide what that is. What is it that we're working towards? I mean, it's easy to say we're working towards improving the care and making the two systems work better together. But what does that mean? What will we look like when we're at full operating capacity as an integrated care delivery system? Very important. I think we've got a pretty good idea of that, but we still got some more work to do, and we need some more input on that. And then we got to tell people about it. If I'm a beneficiary out there in Montana, why do I care? Why do I want an integrated healthcare delivery system? We need to tell folks about it. We need to educate our providers, both in the direct care and purchase care sides. We need to educate our contract staff. We need to educate most of all our beneficiaries and say, this is why we think this is going to help you, and this is why this is a good thing, and we need your help doing this. There are some service unique processes and definitions. Right? No offense to the two outstanding gentlemen to my right, but I don't think either one of them is ever going to need to provide health care on a submarine. Very likely. Any more than the Navy is going to need to learn how to provide health care to people that drive tanks. Hopefully. Now, I will say this, though. As we move towards greater integration and more EMISM, you will see more cross-service work like that. So maybe someday an Army medic will be practicing on a submarine. Could be. I think that's not impossible at some point in the future, but we're certainly not there now. So there are some service unique processes and definitions that we need to keep in mind. We have to respect. We don't want to, disrespect the service traditions, but at the same time, we want to move folks closer together as much as we can. Some unique service requirements. Things like the right of first refusal, like authorization. In some cases, there are rules that are different amongst the services that we probably need to change. We probably need to work out and make ourselves more consistent. And maybe there's times we need to respect those differences and work around them, because maybe they're there for a good reason. I mentioned the differences in the purchase care and direct care systems. This is definitely an area where we need to minimize those differences to the greatest degree possible. Now, I don't know that we'll ever have truly one system of care where there's no difference between purchase care and direct care, but we can certainly move a lot closer than we are today. But there are some differences there, differences how the systems work, how they provide care, and those are challenges that we're going to have to overcome, and we're going to have to win the confidence of both sides to get them working closer together. I already mentioned information technology. Lots of work on that front. I think once we get the common EHR that everybody can use, I think we'll be far ahead of where we are now. And I think that is one goal that may well get accomplished here in the next 3 years. I think that is very attainable. Data sharing. Obviously everybody's a little reluctant to share data. There's privacy issues that are very valid. There's HIPAA issues. We need to be careful about that. Sometimes there's also territorial issues that maybe aren't quite so valid. So we need to work out ways that we can share data across the enterprise between purchase care and direct care in a way that encourages confidence, that patients feel comfortable with, but lets us get the information we need to the people who need it as soon as they need And finally, obviously, we have budget submissions that change the landscape of the health plan. Some of those we may not know yet. We don't know for sure what's going to be in PB 17 or 18. You know, for example, in PB 15, there was the proposal to eliminate TRICARE Prime, have one TRICARE, not a Prime and a Standard. It didn't get approved, but you know, that's the kind of thing that we have to be ready for as it comes out in the future. Okay, so last slide. Let's talk a little bit about an example, how this can work. Now, and I will tell you that the example I'm going to give you is still fairly early in the process. This is not at all full operating capacity, but it is a good start, I think, and it is making great progress. So in our South region, where we have the TRICARE Regional Office, the Managed Care Support Contractor, and the EMISMs working very closely together. So what are some of the things that we're already doing to try to make us move towards this integrated model? We have a single senior level POC that supports work on the EMISM business initiatives. So very closely working so there's constant communication between the contractor, the TRICARE Regional Office, and the EMISM, and therefore it's the MTFs in the EMISM, to work together, bringing the care into much more closely to one system. A lot of data support there. You know, they look at a lot of data and they share that data to a greater degree than most places, and that's proving to have good rewards. You know, they can make better informed decisions with better data, and I think they're doing that. So, you know, the NAS, for example, is one thing that they're taking a look at, and they have now the data to answer that question better. Developing initiatives to support the achievement of the business plan. So, for example, when the contractor works closely with the EMISM and with the TROS support, they can look at, can we recapture ER care? You know, or can we, if let's say somebody shows up in a civilian ER and needs hospitalization, well, let's get that civilian ER to give the MTF a call and give the MTF first crack at that admission. Now, that obviously requires some things. The MTF better answer the phone, right? And they better be willing to make a decision pretty quickly whether we take this patient or not. Do we have the capacity to take care of this patient safely? Can we transport them safely? Lots of things that have to be answered, and it has to happen quickly, because if you make the ER wait too long, they're going to take the easier option, right? Which is probably put them in their own hospital. So, but this is the kind of thing where if we have good data and we have good collaboration between the contractor and the MTFs, we can get these kind of things done. Improves quality of care, reduces the cost, improves readiness. So a win all the way around. Same thing with specialty referral capture. We've been working on that for a long time, but I think this kind of model gives us some new tools to do better at that. Mentioning the interface with the managed care support contractors. So they're going to be defining integration processes here in the coming year. They're the first ones to do that, and I think we're going to have a lot of great lessons learned from this, from what we're doing here, that we can then apply across other markets. And finally, the TRO Regional Director, who happens to be located in the South, in this case, attends the EMISM leadership meetings and briefs them. So again, there's communication between all three parts of the triangle here: contractor, MTFs, and the TRICARE Regional Office. And when you put all three of those together, you can get some much better outcomes. Okay, so that is the last slide. You can tell I didn't pick the picture for the question slide. Won't say who did. But with that, are there any questions? Yeah, Evan.
Quick question. I like the concept. I'm wondering if you have looked at focus groups from the end user perspective, from the customer, the patient who's coming into your hospital. Where in the paradigm does that voice fit?
I think that's a great question, and we probably haven't done that as much as we should. So I think that is something that we're looking at. You know, we have done it for some specific things, you know, for like autism, for example, but I think in terms of shaping the whole system and where we are, you know, we certainly get feedback from the customer, but sometimes it's one letter at a time or one comment at a time. So I think that is an area where we need to do more, and we will do more. So thank you. Yes, ma'am.
I apologize, I came a little late. I'm a VA provider, and every day I see active duty people, every day, at the VA in Hampton, Virginia, which is one of your large market areas, because I do the disability portion of the medical evaluation boards. And I kind of roll my eyes and I say, why am I physically not doing it at Portsmouth Naval? Because 80% of my active duty are Navy. Sure. And they say it's a space issue. And I think my supervisors have just sort of given up, because we could provide better care and it's easier. I'll be quite honest, the data sharing, trying to get on this thing called joint legacy venture and trying to look at medical records is much easier in Alta than it is going boink, 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 boink on this portal. So it's just a thought. I know that physically we actually do have a couple of my providers at the Portsmouth Naval, but they just said, and we could easily fill a couple more space, but they just say physically there's no space, just as a thought process. And I know it's not TRICARE, but we charge money.
Yes.
Is the double wide okay in the interim?
So, you know, what I would say to that, though,
And I cover Langley too, but I'm much smaller Langley, and they're across the street from me.
so I actually was at Portsmouth for a long time, so I know what you mean about the geography, and I will say I think Portsmouth is space constrained. What I would say, though, is that the VA is a member of the EMISM. You know, so when we have these EMISMs, the VA hospital, and I don't know for sure because I'm not sure, I don't know that market that well, but certainly in the Northwest, the VA was an active member of our EMISM, and the VA rep came to our meetings. So hopefully that's happening there too. And I think that is one way we can improve the integration, like you said. Now, does that necessarily solve a space issue? Maybe not. But I think that there is certainly the opportunity there for some communication and seeing what we can do to improve that. I think that's a very good point. Thank you. Anyone else? Yes.
Yes, from the dental standpoint, on one side, I really feel a lot of dental brought into the DHA concept, but I know that when we're talking about networks, we're talking about a considerable number of networks and a large variety. We're also talking about the active duty and the selective reserve. And so my question is, has there been a lot of thought into the active duty dental care program, the active duty referral network of United Concordia versus the TRICARE dental program of MetLife versus the Army Selective Reserve LRN system that primarily uses LHI under the Readiness program? All those elements, of course, beg the question about how we can get interoperability and how we can also develop a information management enterprise solution so that we can upload the data and have a seamless federal continuum of dental care. So, pertaining to your area, I just wondered if folks have been looking into those areas with network interoperability and the electronic enterprise solution. Thank you.
Thank you. And I can tell you the short answer is yes. We actually, in health plans, we actually have 4 active duty dentists who are very actively engaged in looking at how do we bring the direct care and purchase care systems closer together. They actually review all of the care for active duty members in the purchase care system to make sure it meets the standards that we would expect in the direct care system. So there is a lot of work being done on that. Now, I'm not a dentist, so I probably don't know all the details well enough to explain them to you, but I can certainly put you in touch with one of our dentists if you'd like to talk with them. You're welcome. Yes, ma'am.
Mary Kay Gathering. I am a nurse reservist at Wright Patterson, United States Air Force School of Aerospace Medicine, for those who are not Air Force. My question is, if we're really serious about looking at a new way to save money and save resources, and a really new approach, and where the focus is on health and not health care,
what role might registered nurses have in this plan? And I don't mean nurse practitioners. I'm a nurse educator of registered nurses. And there's a whole lot of them still in all the services. And many of them with the decline of MTFs are administrators in clinics. They're not able to really practice to the full extent of their scope. And I would ask that you consider the role of the RN in dealing with so much of the healthcare that does not need a procedure, it doesn't need a prescription. With all respect to graduate medical education, there's an awful lot that RNs could be doing in the management of health for all of our folks.
You know, and I certainly agree with you. I can tell you that as a provider myself, I rely on the nurses in my clinic a great deal, and yes, some of them do administrative work, but they also provide a lot of patient care. And you know, I think that's true, and I think that there are many ways that we can utilize RNs and other medical professionals too, besides just providers, in moving this forward and increasing the integration and ensuring that the patient is getting you know, really holistic care, and that it's focused, as you mentioned, on health and not just health care. And I think nurses have an absolutely critical role to play in that. Now, I will tell you that some nurses I've met have been the greatest administrators I've ever worked with, so I wouldn't want to completely take them out of that role. Having said that, we can't provide we can't maintain health, we can't provide prevention, or health care for that matter, without them. So I absolutely agree with what you're saying, and I think we do need to look at how can we ensure that we continue to enhance how we utilize our nurses and other professionals to make sure they are working at the top of their license and doing everything they can.
I'd like to pile on there just for a second, because that brings up a good point. You know, healthcare, whether it's in the military or outside the military, is a team sport, you know, and we all have our roles and responsibilities. But I had this issue recently, because this is an ongoing challenge with the way we utilize our medics, our enlisted soldiers, corpsmen, you know, our medics across the force, because we don't optimize their roles either in many cases. And I'm looking at Command Master Chief Prince over there, because I know he's got some thoughts on that too. So as we move to the future, we have to look at where we have folks in the inventory and what we have them doing. And if we're not optimizing their, you know, their positions, they're slated against an authorization force, the force will correct itself and it won't be in our benefit. Because what we'll do is we'll do those authorizations. And so we've got to be very careful in how we I think, utilize those professional skill sets that these folks have. Right now, if I think about Army medics, for example, 68 Whiskeys, they're the second largest military occupational skill in the Army, second largest. I think in the Navy, the corpsman's number one. That's a lot of firepower right there, medical firepower. And is it being optimized? I tell you, it's hit and miss. I know that they're not. I mean, you've got guys doing all kind of stuff. You got medcanics, you know, for gosh sake, working in the motor pool. So we've got to be more efficient that way too. I mean, absolutely. So, and I see that on the nursing staff, I think that there's an education role for nurses, though, because I think I think the best officers are products of good NCOs. I think the best doctors are products of good nursing training during your training. I know that was my experience. So, we want them to be obviously involved in the training aspect of our medics and our physicians and our nursing staff too. So I don't think we want to take them out. I don't think you were asking that specifically, right? But I think we have to look internally. And so part of this is from the 90,000-foot view of the DHA, Roger, there's an education and training element. The director of the director of that education and training division or directorate is sitting right in front of me with Brigadier General Miller. But he's looking at things from a very strategic level. The services are going to have to do some hard work themselves to make sure they're optimizing those individuals, whether it's their civilian workforce or their uniform workforce. And it's an ongoing challenge. It's a great point that you brought up, so across the spectrum. Command Master Chief, do you have anything you want to add to that?
I'm glad that you brought that up, sir. I'm Command Master Chief Prince, Senior Enlisted Advisor to the Defense Health Agency Director. And this is a conversation that I've had at my last two commands as well, as CMC at Naval Hospital Camp Lejeune and then again at Walter Reed Bethesda, and utilizing those enlisted corpsmen and medics to the best possible way that we can use them in a facility. And considering the history of the last 13 years and sending a number of our soldiers, sailors, airmen overseas on deployment, was understandable that we had to fill those gaps with contractors and utilize different assets in the inventory. But those soldiers and sailors and airmen are back, and they have this unbelievable level of experience that we're just trying to figure out how we use that best in our facilities. To the credit of the services to this point, based on the efforts of civilian sector, we are starting to qualify. And most recently, the Navy's announcing that 11 of our NEC's Navy enlisted classifications within the hospital corpsman rating will require professional certification for which the Navy will pay for to maintain. Things such as lab technicians, x-ray technicians, and that's an effort that was developed from our METC colleagues, and it pushes the professionalism of our force. And so I ask you as leaders, and we talk about this all the time in our hospitals, are we utilizing those NCOs as best as we can? That's as General Thomas said, it's hit or miss, and that's really to each command to see how they do it. At Walter Reed Bethesda, the nursing staff there came together with the enlisted force, and they created a standard template that they used for all the medics so that you could get and understand what each of them can deliver and what you can authorize them to do. Thank you, sir, for a chance to speak on that.
Thanks, Master Chief. And just one other comment. A couple years ago, during a previous assignment in the Pentagon, because I'm going to hand this back to Captain Simmer, because he's going to kibosh this thing, because we're going to drive on to the panel, I think, in a moment. But
Not without calling on the dean.
oh, the dean's got a question. But for example, we had the vice chief. I was working in the Pentagon, and the P in PTSD is for Pentagon, in case any of you were wondering about that. The vice chief of the staff of the Army was he had 14 of 19 deployed brigade combat teams were yelling for more medics. Need more. These are guys engaged units in combat. He wanted more medics. So we did an assessment, did a layout for him, and he increased the authorization to 42 medics per brigade combat team based on our assessment. And he goes, okay, I'm going to have to pay this bill. Went into the chief, and the chief said, it's going to cost me a lot of money. Where am I going to get those? Well, what we did an assessment, found out what he already had in the inventory and where those guys actually were. He didn't have to buy a whole lot more. We just put the guys he had in the inventory to work and just shifted them over there.
Took about a motor pool, right?
Hua. That's exactly what happened, you know. So we've got a lot of folks, and especially if you have folks that are talented folks, we tend to let them, you know, keep giving them the ball or get them matriculating into other lanes. We got to get them back where their core competencies are, because that's what we need them as an enterprise. That's the efficiency we're driving for. And so what we're doing in the DHA, one of the things, and you've already alluded to this, but organizational review to see if this organization looks right, where the people are, and that's also what we're doing we're driving forward in the EMISMs, to make sure we're actually optimizing those positions and those skill sets that those individuals bring with them, and making sure that they're not in the motor pool. Cool.
Thank you.
Dean?
Yes, Dean.
John Thomas, I just wanted to echo your comments. Thank you for bringing up the issue about enlisted providers. I would simply say it is not an ongoing challenge. It's a tremendous opportunity to enhance readiness, to reinvent and redefine primary care, and to achieve the kind of goals you're looking for. In the civilian world, we do almost 30 million EMS contacts a year. 99.9% of those are done by non-physicians, but with explicit backup from medical direction. So I think that there's incredible power in this concept. It's the kind of ideas that will transform the military health system and ultimately transform American healthcare. So thanks very much for bringing that up.
Thank you. All right, well, we are way over time, and the nice young lady in the back has been holding me up the red sign saying I've been out of time for at least 5 minutes. So, but the good news is that we're going to go straight into a panel discussion in just a minute. General Thomas and I will be back here. Master Chief Prince will be joining us, and also Mr. Mark Ellis from TRICARE. So if you have more questions, it's going to be a short presentation and then plenty of time for questions. So please stand by, and if you had a question that didn't get answered, we'll get it taken care of. Thank you.